Hello, my name is Angharad Jones and I'll be presenting our research on the anal endosonographic assessment of the accuracy of clinical diagnosis of obstetric anal sphincter injuries and the correlation with anal function and bowel symptoms. The aim of our study is to assess the accuracy of clinical diagnosis of obstetric anal sphincter injuries using the gold standard assessment tool of anal endosonography. Very few other studies of our sample size have previously looked into this, especially from a viewpoint of women who have previously been clinically diagnosed as opposed to the follow-up of women who may have had a tear missed at delivery. Obstetric anal sphincter injuries are a common cause of maternal morbidity with an overall incidence in the UK of 2.9%. Women who have injuries diagnosed at the time of delivery undergo primary repair. However, residual defect persists in many cases following this. This can contribute to a range of physical symptoms and psychological distress. This study looks particularly into bowel symptoms such as fecal urgency, fecal incontinence, post-defecation soiling, or flatus incontinence. Women were classified according to Sultan's classification, with 3rd and 4th degree tears constituting an obstetric anal sphincter injury. 1,135 women were seen at our 3rd and 4th degree tears clinic between June 2008 and October 2019. 1,112 women successfully underwent endo-anal ultrasound and anal squeeze pressures were recorded for 1,017 women. Over 20% of women with clinically diagnosed obstetric anal sphincter injuries did not have an injury confirmed on ultrasound. Nearly half of the women in our study had a mean maximal resting pressure below the normal range, with 69% having a mean incremental squeeze pressure below the normal value. Both squeeze pressures were significantly reduced in women with injuries confirmed on ultrasound. Over a third of women reported one or more bowel symptom, with flatus incontinence being the most commonly experienced. Women with confirmed injury on ultrasound were significantly more likely to report bowel symptoms. Women who underwent instrumental deliveries or received epidural analgesia or an episiotomy were significantly more likely to have an injury confirmed on ultrasound. There was, however, no significant difference between forceps and ventouse deliveries. The mean age of the women in our study was 32, with nearly 80% of women being primiparous. We did not find any significant difference in confirmed injury rate between primiparous and multiparous women. In addition to this, we did not find any difference in the mean birth weight of babies born to mothers with or without confirmed injury. Women of Asian ethnicity were significantly more likely to have an injury confirmed on ultrasound when compared to black women, but there was no significant difference between any other ethnic group. Over 20% of women could be assured that they did not have an injury confirmed on ultrasound, and therefore have no contraindication to future vaginal deliveries. However, the high rate of clinical misdiagnosis suggests there is room for improvement. The women who did have injuries confirmed on ultrasound were discussed at our MDM, and patients were offered early treatment to encourage better long-term outcomes. Anal endosonography can aid in the confirmation of obstetric anal sphincter injuries and help in planning future deliveries. Those with confirmed injury on ultrasound are more likely to complain of bowel symptoms, particularly flatus incontinence. Anal sphincter pressures were significantly reduced in those with injury confirmed on ultrasound compared to those with no injury.